not involve the pulp. It's that easy. So if it involves the pulp, there's two options. The pulp's visible. We're either going to probably do a root canal. Sometimes we'll try and do a pulp cap and cover the nerve. If the root canal is not available, then we extract the tooth. Because once that pulp is visible, it's painful. That's exposed nerve. With the uncomplicated crown fracture, like this guy right here, you see how the tip's off? Again, always ask the patient to bring the piece of the tooth so you can verify where it is, especially if there's a laceration. You want to know where it's at. And the other thing is we can clean up that surface, stick a little bonding agent, and we can rebond it. So we can rebond a broken tooth and make it look really nice. So it's a nice way to good service for the patient if you have the dentist handy. Is it time right now when I pick it up? All right, dental trauma, the one that you guys are going to see the most, I mean, I can ask about any of these. Lateral luxation just means it's moved in the socket forward or backward, side to side. Extrusion means it's partially out of the socket, but it's still in there. Intrusion, imagine someone falling or hitting something, and it gets impacted, so the tooth actually goes further up, and it's intruded into the socket. The one that I'm going to talk a little bit more about is the avulsion, because that's something that y'all can help with. If someone comes in and the tooth is completely avulsed and out of the socket, you can help put it back in place. With all of these, we're going to fixate it afterwards. We usually will use like ortho wire that's not active, that's not going to help move it, just hold it in place. In the field, start thinking like, what could I use if I don't have access to orthodontic wire or dental equipment? I've seen some real creative people use thick fishing line, like thick fishing line to hold it in place. I saw someone take a paper clip and open up the paper clip and shape it to the teeth and then fix the tooth in place by gluing the paper clip to the tooth. So there's ways that you can help keep that tooth in place even if you don't have access to the dental materials typically. But when you get an avulsion, to keep it alive, it's covered in periodontal ligament cells. That's what we're trying to keep alive, the PDL. How do we do that? We stick it in the right storage media, a glass of milk, whole milk, real milk. I know now we have oat milk and almond milk and all kinds of milks that confuse me when I go to the store. But if you put it in a glass of milk, that's going to help keep it alive. There's oral rehydration solution, which you can make. The recipe's right there. There's also, this is the one that if you're ever working with a softball team or an ice hockey team, sometimes they'll have a dentist that's with them as well. If you can order that paint balanced salt solution, that's one of the best things for saving the tooth. So if you're in it, you're a coach or you're helping out with sporting events, and you know that there's a likelihood of someone avulsing a tooth, it could happen. Having that paint balanced salt solution on hand is excellent. Your cheek, the patient's cheek, not necessarily your cheek as the person who found the tooth. But if I were to avulse a tooth on myself and I wanted to keep it alive, I could stick it back in my cheek to help keep it alive. Does that make sense? Now, what patients would you not do that on? They're unconscious. They're unconscious, don't stick something, a foreign object, don't stick it back in their mouth. And then I think little kids, depending on their age. Now, what did I tell you about kids if it's a baby tooth? If it's a baby tooth or a primary tooth and it's avulsed, it's gone. We're not sticking it back. That doesn't happen. Or just saving the solution. What you don't do is tap water, you don't do Gatorade, you don't wrap it in tissue or come in where you're holding it in your hand. The PDL cells are going to be dead. And I kind of tell people it's like a golden hour. The golden hour is still alive with dentistry. I know it's not alive with medevac and stuff as much, but if we can get that tooth reimplanted within an hour, the chance of it surviving is excellent. And that means the PDL cells survive, so it has normal attachment to the socket. If it's more than an hour, what often happens is the PDL cells is dead, we stick it in there, and it ankyloses. Have you ever heard of ankylosis of a tooth? The tooth will change color, it'll be dead, and the PDL will have no movement anymore. It's anchored to the bone, like an implant with no PDL. So it doesn't move. And if you percuss, if you ting, ting, ting with the back of a mirror or the back of a dental instrument, it'll have a high ting, ting, ting instead of a normal sound, a little bit deeper. once it's ankylosed, you can think of all the problems. The nerve's dead, it's not moving. You can't do ortho on it because it's not going to move. It's ankylosed to the bone. It just looks unaesthetic. This is one that was reimplanted and then ankylosed. So not only did it ankylose, but we got some resorption. You can't really see where the periodontal, see here you can see the space. Here it kind of disappears, where the bone is just eating into the tooth. So you want to reimplant that ankylosed tooth within an hour, less chance of ankylosis and resorption. So they did the root canal on this, but the tooth, you can't really see where the root is. It's not clearly defined here, it blends in with the bone. So it starts to resorb. This is probably all that's truly left of this tooth, maybe right about there, and then it's got a little tip down here, and it got a virgin. Don't scrub this root surface. You don't want to injure the PDL cells, so you can lightly rinse them with saline. You don't want to scrub. I mean, I had, when I was in Bamsi, I had someone came in and the girl was wearing braces, so it was really easy. The teeth were still attached to the brackets and just flopping around. She took a softball to the face. And when she came in, we peeled back the gums and kind of cleaned everything off and we put the teeth back in. It was the coach watching that fainted that needed medical attention. So be careful when you're doing stuff like this because the family members or the other people in the back, sometimes they're not used to the sight of blood or issues. They might need attention. Because it looks pretty hairy. An empty socket with blood in it. Yeah, but it was kind of nice when she came in with the teeth still attached to her ortho wires. Less than 60 minutes or greater than 60 minutes is a poor prognosis. If they damage the root surface or let it dry out, what storage medium also has an impact. So I told you to get storage mediums. All right, we're getting near the end of this lecture. With mandibular fractures, there's only a few key things I want you to know. Usually if they have trauma, there's multiple fractures. You have to look at the patient to see if you can identify it. Here's a good photo. So you can see where the occlusion should be and how there's this sudden break and drop. Pretty sure there's a fracture of the mandible down below there. And there's also going to be a fracture on this patient to one of their coronoids because you can see the jaw is shifting. So that means one coronoid's not in position. So they probably have a fracture right here and probably a fracture somewhere around the condyle. So you're looking for these different ones. There's a couple percentages on the next slide. I just want you to memorize like the most common and the least common. So the most common are the condyle, which makes sense. When you get hit, that's where the impact's going to be. And one of the least common is the little coronoid process that's sticking out. It's not bounded by anything. It's kind of free floating, so it doesn't really have anything to bump up against the break. So most common and least common, kind of keep that in mind. My favorite story about fractures, mandibular fractures, is I've never met someone in the military that got hit in the face that deserved it. They were always the victim. Every story I get as a dentist was, I was just minding my own business. Or I came to the rescue of my battle buddy. Or in Hawaii, you can see it a lot when they blamed it on, it was hit the Howdy days, so I just got sucker punched. So it's fascinating. I love getting the stories of what happened, and then I put it in the records because I'm realizing no one really reads my dental records. But I'll put great quotes if the patient ever says a really fun quote. But most of these, total just victims. They were in the wrong place at the wrong time. Never instigating. Truly believable. Any questions on this lecture? Does it make sense, like the kind of questions I'm going to ask? I want to make sure you all understand. Like, I'm not going to be tricking you. It's going to be pretty straightforward dental questions on my part of the exam. Let's move on to the next lecture. Oral pathology. So this lecture, I will say I tend to grab extra questions out of oral pathology. Just looking at the exams that you all usually what's the diagnosis or what's the treatment. Those are usually the things. For dental, for us, it's usually more of what's the diagnosis. We name what this is based on the photo or the description. You guys tell me the difference between periodontal abscess and periapical abscess. Periapical is at the apex of the roots. Good. Periodontal is going to be lateral to the tooth in the periodontal pocket. Good, good, good. One's going to be due to bacteria in the periodontal pocket. That's you'll know it's the periodontal abscess. And then the bacteria present in the pulp and at the root apex is that periapical. How about vitality? Which tooth is vital? The periodontal has a vital tooth. The periapical is non-vital because it's got a necrotic form. And then the location, which you guys already described very well. So the gum, the gingiva, that's the periodontal abscess, and the periapical abscess is the tooth. All right, let's talk about some normal to benign. There are variations of normal. So you'll see extra pigmentation in the gingiva with different races. It's not always going to be that coral pink. Sometimes it'll have more of a purple color to it. So you just kind of look around to see, you know, is it everywhere? Is it bilateral? Is it symmetrical? Look for what's normal. Stippled, firm. The tongue, again, foot stomping because I talked about the tongue in another lecture. The types of papilla. There's filiform, fungiform, circumvallate, foliate. Filiform are fine hair-like and the most populous. There's most of them. The fungiform, round raised spots. They look like little fungi, mushrooms. The circumvallate are in the back. They're usually raised, V-shaped. And the foliate are on the lateral. Tori. I see this all the time. And I like to tell people that they've got tori, whether it's the mandibular or maxillary tori. This is a variation of normal, slow-growing bone, either in the hard palate, these guys here, or it's the lingual side of the teeth in the mandible. One reason you want to know if you have tori, the people who have like mandibular tori, they hate getting bite marks done or x-rays in the mouth. Like, we'll put the film in there and it's going to scrape against where that extra bone is. Because most people don't have tori, so we're usually just sliding that film right behind the teeth. So if you know you have mandibular tori, let the radiologist know, hey, before you take my x-rays, I have tori. Please don't scrape up my tissue back there. Up here with the palate, most people just have a little bump. Not everybody has a bump in the roof of the mouth. Those of you who have one that kind of sticks down, that's a tori. And it's slow growing. It may get bigger over time. Most people's roof of their mouth is more concave rather than sticking out. Problems with this, all of these, if you lose your teeth. Think about the dentist now has to restore you with a denture. How do I make a denture fit over this bone? I aggressively remove the bone. Who am I going to send it to do that gum surgery or that oral surgery? Either the periodontist, who's a gum surgeon, and they're gentle, or the oral surgeon, who's not as gentle, but damn, they're quick, and they're professional. Like I get the opportunity to work with both of them. And when I work with oral surgeons, they're timers. Or high-fiving at the end of the procedure if they did it quickly. And their concern isn't so much, did we do a great job? Is the patient okay? It's not so much with how the tissue is going to do or the healing is going to be. It's time. I got those teeth out in 15 seconds. That's amazing work. The periodontist, they are much more concerned because they're gum doctors. They're concerned with how they've done it. So my hint to you with that is, if you ever have a surgery coming up, if you want it done quickly and professionally, no messing around. Oral surgeons are usually great. But if you're worried with how it's going to look, like if it's in an aesthetic area, I would recommend you consider a periodontist. They're going to be much more aesthetic. But yeah, so this is kind of brutal. If you ever see it, they fillet back the tissue and then they create little tiny grooves on both sides. And I'm not kidding when I say they usually bring out a hammer and a chisel. And they do a little woodwork. So after they create the grooves, they knock off the bone. It is. So if you have tori, take good care of your teeth because you will not want to have a prosthesis in there later on. And again, these are slow growing, so that's another reason to get them removed. I've seen them where they get big enough that they're touching. So they'll keep growing, and eventually they touch and cut off the tongue. So problems with that, you'll see food and bacteria get lodged underneath the tori, or maybe it starts to impact their speech. So then we'll also remove them. But it's benign, variation of normal, mandibular tori, maxillary tori. Exostoses are slightly different. Instead of being on the palate of the mouth or on the lingual surface, they are on the buccal surface. Variation of normal, extra bone. It's almost, I call it buttressing bone. And the people who I see this in most often are bruxers and grinders and clenchers. So they put extraordinary forces on their teeth, and the bone thickens as a result. Right off. So exostosis is just extra bone on the buccal, the maxilla, or the mandible. For all these, there's no treatment needed unless it becomes an issue with restoration, prosthetics, and when there's treatment, it's removal of the bone. Any questions so far? Glossitis, enlarged tongue. You'll see it in some syndromes like Down syndrome, hypothyroidism. You can see it can be congenital malformation. Treatment, usually there's none again. This can be a variation of normal. Speech therapy, sometimes they will actually thin out the tongue and do surgery. I don't recommend it for people. If you see glossitis due to nutritional deficiencies where the tongue looks bald, like a bald tire, it can be due to nutritional deficiencies, niacin, riboflavin, iron, vitamin E. I've never seen this, so you have to sit down and kind of review and a food journal. Dehydration, irritants, autoimmune diseases can also cause it. Glossiodinia is where you have glossitis with burning. So it's all the same things with glossitis, but they'll get a burning sensation, burning mouth syndrome. Everything that can cause glossitis, to include nutritional deficiencies, drug reactions, autoimmune conditions can cause glossiodinia. Again, you can try and find the underlying condition and treat it, change medications, smoking, behavioral therapy. You gotta let the patients know it's not cancer. Ankyloglossia. So this one's cool. We call it tongue-tied. I think I was talking about freedom. So this has a thick lingual freedom. See where it attaches almost to the tip of the tongue and kind of binds it so they can't stick their tongue out. So lots of times we'll identify this in children because it impacts their speech and it can impact their feeding, and they'll try and correct it. So short, thick lingual freedom attached far forward on the tongue, limiting movement of the tongue, can cause speech. It's usually present since birth. Correct with the lingual frenectomy. If you're an adult or even a child, like I would recommend again our friends, the periodontists. I've seen them do this one, and they have you can do it with laser, you can do it with a scalpel. But I really liked like the periodontists when they were doing it. And do something new. They would put sutures where they wanted it to end before they even did the surgery, and then they would remove the tissues. That was kind of cool to see a different technique. You can imagine they were suturing like the base, that floor underneath, and then even up the tongue, and then they just went in and removed everything and separated it. Oral surgeons are really quick at doing this, but they get it done as well. A general dentist offers to do it. We can do it as a general dentist or comprehensive dentist, but I would prefer a periodontist to do it because they're going to handle the tissues so much softer. And when it's done, they'll be able to stick their tongue out a lot further and speak a little bit clearer. So again, tongue-tied, technically ankyloglossia. Hemangioma. That's vascular. You can kind of look at it and tell it's vascular. If you ever see a condition and you're wondering if it's vascular or not, aspirate. So you can stick a needle in there and try and aspirate, and that'll tell you if it's vascular or not. Blanches when touched. Yep, superficial. Genital, it can grow. Usually no treatment is necessary unless it's aesthetic or desired. Steroids and laser therapy. We see hematomas a lot more. The hematoma is just a big bruise, red, brown, blue lesion. Does not blanch on pressure, so it's due to trauma. Again, it's just a big bruise. And you observe, again, I think I told you my rule, 2 weeks for pathology. If it hasn't changed, it still looks the same, or it's getting worse after 2 weeks, I get concerned. So observe, bring them back. If you're wondering what the recall time should be, bring them back in 2 weeks. is a great one for question. I usually will vary just the milliliters and then ask what it is. So memorize the difference between petechiae, pleura, and ecchymosis. The ecchymosis is the largest, and petechiae is the smallest. So these are just kind of small hemorrhages in the tissue, again due to trauma. So memorize the difference. When we have people say "ah," sometimes we can see the little bruise in the back of the mouth. Good slide to know because it has numbers on it. Lingual varicosities. You see this in old patients, and one of the, like I would see it in civilian practice all the time, but in the army, in the military, what's the age of my patients? They're like 18 to 25, most of them. I walk in and get seen as a 50-year-old, and like I feel like ageism is alive and well. Like I have to put in my date of birth, and then they always take my blood pressure and tell me my blood pressure is a little high. It's like 132 over 85 or 82. Like I feel like I'm doing okay. Is it because you're used to seeing 17-year-olds? I don't know. Maybe it's a lot. Okay, so you see it in older populations, you just don't see it as often in the military, but when they lift their tongue, it'll almost look like a varicose vein on the ventral surface of the tongue. Asymptomatic, it'll blanch on pressure, no treatment needed. Amalgam tattoos. The thing with amalgam tattoos is you have to rule out the dangerous lesions like a malignant melanoma. So if you see this and you're not sure why it has that discoloration there, if you take an X-ray and you see a little piece of amalgam pool, it's pretty easy to rule out. That's amalgam tattoo. But if the patient doesn't know, if it's something new that they never saw before, you can get oral signs of malignant melanoma before the patient's aware that they have it. So, blue purple discoloration, usually associated with material like amalgam. Again, once you know what it is, if I didn't know what it was, I would do more investigations, trying to figure out, bring them back, and do maybe a punch biopsy. Melanotic macule, this is just a mole. Round macule, genetic solar radiation. Again, usually you have to do a biopsy to rule it out. Once it's confirmed, no treatment is necessary. So I'd say very similar on these. You just need to know what it is, pop it out. Hereditary oral lesions. People are like, I've had this since I was 2. It's always the same. I'm not too stressed about it. Usually it's symmetric. And usually it's stable. The hard thing is if you see something and you talk to the patient, they're like, I had no idea. I've never seen this before. So then you have to follow up with them and see if there's any change, and that's where I would typically send a biopsy out just to confirm. It's something that they weren't aware that they had. All right, melanocytic nevus. It's another intraoral mole or freckle. It can be blue, black, brown, sometimes raised with a smooth surface. Yeah, you just have to send it off. Microscopic examination, so send it off to PATH for confirmation. No treatments needed if that's what comes back as. But we're ruling out the bad stuff by getting sent it. Okay, this one's cool. This one a lot of people have. Benign migratory glossitis. It's also known as geographic tongue. So more likely than not, at least 1 or 2 of you have been in this classroom have had this, and you weren't aware what it was. And it's called migratory because it moves. It doesn't stay in the same place. It'll affect different parts of your tongue. You'll get multifocal red lesions with white rims that migrate and move around. And it's eroded areas. You lose your filiform papilla. So you lose that little hair-like papilla, and it looks smooth in those areas. Sometimes you can get a burning sensation with it. Etiology is not known exactly what causes it. Typically, no treatment's needed. I would recommend just make sure you clean well. Tongue brushing is going to be more important for you. Tongue scraping. And you might want to avoid spicy foods if that irritates you. So benign migratory glossitis or geographic tongue, very cool presentation and usually easy to identify. is your tongue. It looks as disgusting as these pictures. You see it? It is associated with some syndromes. They will get food and bacteria stuck in here quite often. So again, tongue brushing and scraping is required. It can be inherited, it can be developmental. I feel bad for people that have it because again, like they'll have more problems with breath or halitosis and just a lot of bacteria and particles get lodged in them. So you want to review hygiene with them. Fordyce granules. Benign, and this just is little pieces, yellow, white. It looks like when you stretch the cheek, you can kind of see it on the inside of the cheek. And it's sebaceous glands, just visible ectopic sebaceous glands. Perfectly normal. About 80% of the adult population has it. If I look in your mouth and see them, I'm not concerned. I just need to know, okay, they have Fordyce granules. Linea alba. It's a raised tissue right where the occlusion is. So it's hyperkeratosis of the buccal mucosa, and it's where the maxillary mandibular teeth get associated. Some people, I mean, I find myself doing this all the time. I'll be resting my teeth on my cheek. So you just kind of close it, bite against your cheek to create that little hyperkeratosis of the linea alba. I had to, again, in Germany, they were really funny. I had a lady come in very distraught because she had this. She wanted to know what could be done. And I kind of gave this spiel with normal, just part of where your teeth come together. It's causing that line. It's not a big deal. It's a little hyperkeratosis. She went to a German doctor and complained about it, and they came back to me and told me what the German doctor said. And it was hilarious because Germans have zero social skills. I feel like. Now, if you're German, I'm sorry, I'm not trying to offend you. The German doctor said, yes, you have fat cheeks, and you bite your cheeks. And so she came back and told me that. I felt bad for her, but at the same time, I thought that was pretty hilarious.
Fat cheeks.
Lichen planus. So lichen planus is visible in the oral cavity as well as not in the oral cavity. This one I'm going to foot stomp because it has this white, yellow, lace-like pattern. And it has its own name, pathognomonic sign, Wickham striae. So it's an autoimmune response. Treatment's not necessary unless it transitions to erosive, painful, and then topical steroids. Sad story, a friend of mine had erosive lichen planus that they were monitoring for like well over a decade. And went in to have it monitored because it was red, like irritated. And they did a biopsy and found it was cancerous and had to do a big resection of part of the jaw. So, and this was a dental professional, so it was like something that they were aware of and monitoring. They still ended up getting cancer diagnosis with it because it was that erosive variation. So it can convert very rarely into cancer, but it can. The treatment is usually none. Just have to be able to identify it. And it can involve the skin and feet. So it's not just oral, intraoral. But yeah, key phrases I want you to remember: lace-like pattern, Wickham striae, and try and lock in what that looks like.
Sir,
Yes,
do you typically include pictures on your tests?
I do. I'll have probably one or two pictures, maybe more. And then for the other path that don't have pictures, I'll paint the picture with words. Have I told you guys my cheat code for whether or not someone has an autoimmune deficiency or AIDS? So I mean, this is just my dental school experience. I went to dental school back when they were showing slides of people doing wet-handed dentistry. You know what wet dentistry is? No gloves.
Whoa.
When did dentistry start using gloves? It was in the 80s in response to AIDS. Prior to that, it was wet. So when I went to dental school, I started in the year 2000, and they were still showing slides of people without the gloves on. And I was like, that's pretty nasty to watch. But I also noticed, anytime they showed a pathology, and it was not the best photo, and there was a hint of a mustache, I'm thinking autoimmune deficiency, possibly HIV. Sorry, gentlemen with the mustaches. I know they're back in vogue now, and they look magnificent. But I'm giving this to you as just keep it in the back of your mind when you're on a test and you see just a hint of a mustachioed man. Because it was very in vogue in the 80s. And this was prior to having good treatment modalities. So you would see a lot of unique autoimmune diseases that went untreated, such as herianoplastia, which is often treatment of underlying HIV infection. Yes, so there's HIV infection which allows opportunistic infections. So you'll see parallel hair-like vertical white lesions that can be bilateral on the surface of the tongue. And it's, again, an opportunist infection with Candida albicans, usually happening at the same time. Epstein-Barr virus, so it's like these infections you normally wouldn't have going on unless you have an autoimmune disease. Treatment is going to be cyclovir and antifungals to treat Candida, cyclovir to treat. Any questions on this? That's my little hint, and I think it applies more than you know. All right, leukoplakia. So I'll usually ask a question about leukoplakia, and I'll pair it with Candida. Leukoplakia is a white patch that cannot be clinically diagnosed as something else, and the white patch does not rub off. So what would I say about Candida? The white patch that can be rubbed off. So I usually try and compare these two. It's a thickened layer, so it's like almost like hyperkeratosis. Usually it is precancerous or premalignant, considered, but it's pretty benign. Like there's not a huge risk of it becoming cancerous. So it's one of those things again we try and send off and say, hey, is this going to become? Is it precancerous? Is there a chance or not? Leukoplakia. So I told you, make sure you know the difference between it and Candida. How about this one? Does this look more likely to become cancerous? So this is what an erosive lycoplanus would look like. You have the Wickham striae and the lace, and you have an erosive function like this. You're keeping track of. Erythroplakia. Red tissue, often linked with tobacco. Alcohol can increase the risk as well. And it's way more likely to convert to neoplasm than cancers. So 90% of these are dysplasia or carcinoma. And they look angry. They look red. There's not a lot of symmetry to it. The borders may not be easy to define. They look bad. I already gave you guys my spiel on tobacco, especially smokeless tobacco. Not the end of the world. A lot of people use it, and the key is if you have use it and you use it in the same spot over and over again, you'll get keratosis, tobacco pouch keratosis. And what I get more concerned about, you can see it here, is the recession, the staining. There's probably some cavities happening maybe on that cementum that's exposed. See some brown, that nice stain there. But if they rotate the tobacco pouch, it's not, the chance of it becoming cancerous is very low. So here's that tobacco pouch keratosis. You can see where they keep it here, that brown staining, and I worry about the caries and about the so it's white wrinkled, you can kind of pull it, and you can kind of see the folds when you pull it out, see where the tobacco goes. Usually reversible after how many weeks? 2 weeks. This we don't see very often because this is due to using a pipe. So you gotta think like Sherlock Holmes. How many pipe smokers do we have nowadays? It's pretty rare. It's not as common as it used to be. But what is popular now? Vaping, mustaches. 2 points to Gryffindor. Vaping. So if it's high vape exposure, I do worry that we might see something like this with vaping if someone's doing it enough. But I haven't to this point because it's associated with heat and tobacco exposure. Nicotinic stomatitis. Look at the coloration of those teeth. Beautiful. This person was not a casual pipe smoker. This was their duty in life. They were taking it very seriously. You'll see it almost, to me, it almost looks like cobblestone. Like just it has a unique experience look to it, and red and flame. All the minor salivary gland ducts are just red and flame. Nicotinic stomatitis. I already talked about mucosal allergies and the other. We were talking about gingivitis. So it's an immune response to the allergen. The treatment is you find what's causing it and remove it. Traumatic ulcers, we do see this a lot as well. Usually it's due to a mechanical, chemical, thermal trauma. Let me give you some examples of things people have done to create ulcers. They had a tooth that was hurting, and so they put a raw aspirin right next to the tooth to help the tooth from hurting. So that's, I guess, the parents or grandma told them that helped. So aspirin is just salicylic acid, right? So it's just going to be acidic. It's just going to erode the gingival tissue. So I don't know. The tooth maybe stopped hurting because there was an ulceration right next to the tooth afterwards. I've also seen people who are very aggressive with brushing their teeth, and I don't know how, but like the toothbrush head, I think when they're switching positions, they rub against the gingival tissue with the toothbrush head. As well. Sometimes biting, like aggressively chewing, you know, I guess you place of where your tongue is. You'll get a little traumatic ulcer from biting your tongue. Cheek biting as well. If you have fat cheeks, you get an ulceration on it. So palliative, try and provide, have them avoid the habit, whatever's causing it. Nothing big there. Aphthous ulcers, very painful, usually last about 2 weeks. And aphthous ulcers usually are precipitated by a stressful event, chemical or food allergy. So different than the traumatic, because aphthous is usually stress or UV related. Making it pretty big. Also known as ankylosis. So you're trying to have them reduce acidic foods, known stress, topical steroids. Unlike cold sores, aphthous ulcers don't occur on the surface of your lips and keratinized tissue, and they are not contagious. So this is on the lining mucosa. You can see it's on the floor of the mouth, it looks like here, or on one of the freedom on the lip. Mucosal burns. Anyone have an idea what this person's chewing on? Electric cords. Yeah, chewing on an electric cord. Children, I mean, they're not the brightest, but look, they were chomping away on the cord that was plugged in. You got a little electric burn. What we worry about here is this can actually fuse and cause this side of the mouth maybe to be a little shorter. So sometimes we'll create something to help keep it separated as well. Yeah, I talked to you about aspirin burns, electric burns, what we see here, thermal burns. In the OR, I saw with pediatric patients, this was a case that was on the news. The doctor had to heat sterilize an instrument they needed real quick, so they did a flash heat sterilization of a dental instrument and stuck it in the kid's mouth afterwards. And it seared, like burned the instrument, burned the child's mouth. So you'll see it with thermal burns, you'll see it with electric burns, you'll see it with aspirin. It'll cause that sloughing and edema. Palliative, and then that deformity is what we're trying to avoid. And sometimes they'll put a prosthesis in there to help keep it separated if it's bad enough. All right, we'll take the first break, and I don't think we're going to need too much more of a break. I took the longest lectures and I preloaded them. So lecture 1 and 2, the first 2 days. Today we'll probably finish a little early, and then tomorrow we'll definitely finish early. I'll do a review with you of some of my questions. So go ahead and take a 10-minute break. I'll see you back at 1:52.
Other stuff, oh yeah, just dental office. It says dental.
Oh, microwave. I'm saying like most of the ones, like that's one of the benefits. Or microwave. But we're here. Yeah, so we'll finish this tomorrow and do a review. Then we got history. So it's definitely something else to come deal with. Good.
What do you got for me? I'd love to know. Curious. I forgot what so it would help. So we put this on just like that.
I've had whatever. I had what I brought yesterday. So that set up it here, and then no one else did something.
I would be the opposite. I would probably be the guy that,
I just think I don't like yeah. And then she started like thinking, she's like, why did you guys miss the first question? Why did you bring my son? She's like, no, they all sent it to me questions. And like, I swear to change wording. Yeah, what's the risk of it? Like what was the risk of growing yeah, like what's the risk factor? What could cause candidiasis? You know, and I told her that, like, I've talked to multiple people who read it multiple times, and every time we read it, like, the words were so weird, and it just said, what is a sign of candidiasis?
I was complimenting you on that.
Hey, I got a lot of the distractors though. So I think at least I'm taking the distractors. Close. Only one. So I got a 60 to give for the guys. I'm in the sixes. Hey, 3 more of those. I want to be under information. I already did, yeah. Like for the calendar. Gotta meet with him every 2 weeks. I'm on academic probation. Just gotta move your academic side there. Just want to make sure they're not seeing a trend. Like, if all of a sudden I start failing. If you no, if you get a 60 below 66. It's on your on the calendar. But like she's like, what'd you go to first test? Like 90. Throws my test. She's like, this is bull crap. Like, and I showed her, like, I showed her on my thing, like, she's like, this is what we wrote, this is like, what's the thing you're supposed to put it on, like, this is what I said, my thing where I wrote it down. I'm telling you, I wrote it down, I studied it, I could not recall it. I couldn't recall it and everything, and so like I just kept looking at it. I'm sorry, I couldn't recall it. Yeah, they were. I learned in 2 weeks. Less than 2 weeks.
All right, it's 1:52, let's get our seats. We're on to infectious, we're looking at viral or fungal infections. before you go to the next slide, how many people have oral herpes?
No.
Go ahead and raise, no, don't raise your hand. Give me a percentage of the population that have, like,
Say 80%.
higher,
Higher than 5.
80%.
higher than 50.
70.
Alright, let's take a look here.
67.
67% have HSV1. So when you have a brand newborn, and some moms are really good about this, they're like, keep the aunties away that might kiss. Keep the grandmas and everyone, all friends and family keep a distance from the child. This is what happens when you're letting them kiss on a brand new baby and they have an HSV1 infection. It's terrible. The child cries, they can't really express what's going on. All you know is you see, it's usually in very young children. They have the vesicles, it's asymptomatic, it's red all over, they'll have a fever, and it's HSV1, primary hepatic gangliosidosis. I did see this in a young teenager with one of her first boyfriends. And there's gotta be a better way and a better person to tell someone they have oral herpes. I failed as a dentist and made this poor girl feel like a social pariah. I felt horrible after talking to her. But yeah, she came in and had the same symptoms.
Yep, you got her.
So usually it resolves in about a week. And in
Yeah,
cases up to 2 weeks, there's that magic number again. It's a lot of supportive care, a lot of diet, soft food. Yeah, and usually afterwards it remains dormant, and then for the rest of your life, you have those pleasant cold sores that can pop up. But yeah, I was looking into the numbers, and so I added this when I was looking into the numbers recently, and I couldn't believe it's like 70%. So don't feel like a social pariah. When you talk to someone who has it, don't make them feel bad. This is completely normal. This is something that pretty much everyone, the majority of people in the world have. And this is what it looks like when it reactivates. Recurrent herpes. You get those little vesicular lesions. It can be on the attached gingiva. Remember I was telling you about the attached and the unattached? So it'll be on the hard palate or the keratinized tissue as well as the lip. Activated by stress, usually people will know. I have a history of it, I can feel it, I can feel the tingling, it's coming on. They'll know what it is. Remember I was telling you about wet dentistry? This is what happens if you stick your finger in a mouth of someone who's got herpes, oral herpes, an active infection going on. You can get herpetic whitlow, and it can get in the fingernail bed. Something else that can happen, because in dentistry we create a mist when we're working. So if you come in and you have an active herpes, just go ahead and reschedule. Don't come into the dental clinic. We don't want to see you. Because it can also get ocular. And especially if we create a mist and we've got the virus just shedding out in the air, we will reschedule you if you show up. Thank you for keeping your appointment. But if you have cold sores or something going on, let's just go ahead and reschedule. So recurrent herpes, yep, treatment should be initiated as early. You can give systemic acyclovir for severe cases. That is what it looks like if it gets in the fingernail bed. Syphilis. So this one, if I were to ask a question about it, I would ask again, I think there's cool words, so I like to, if there's something unique, I'll put the cool word on there. Treponema pallidum, I think that's kind of cool sounding. The central depression, chancre. I mean, when else do you ever hear chancre? So it's kind of like, for me, it's kind of unique. So if I write a question, I'll try and put key words in there that should jog your memory. Because I'm not going to put a lot of pictures probably with syphilis. All right, here's what it looks like. They'll tell you that they came in contact with an infected person, and it lasts, the chancre heals. If they don't get treatment, it'll progress. The treatment is just simple, cheap, high-dose penicillin. Before we go forward in slides, anyone know how we know so much about syphilis? We tested, we denied, while knowing they had syphilis, to go test TB. Yeah, so we, in America, did some pretty shady stuff. And I bring this up because when people say, I don't really trust, I don't want to get a vaccine, I give them a little benefit, and I say, I understand. We're not perfect, and it's okay to have doubts. But yeah, so we know about secondary stuff. I mean, imagine living with this and going to the doctor for 2 months and not getting treated because we wanted to see what would happen and what secondary syphilis would Grayish white plaques covering the ulcerated mucosa. Again, it's going to be shedding the virus, rash on palms of hands and feet. You'll get lymphadenopathy, a sore throat, malaise, just not going to feel good. It's highly infectious when you see the mucus patches in the mouth. And this is, I don't know how well you can see on this, is right there. Mucus patches. Ulcerated mucosa. And so I put in here because this is when they did a syphilis experiment where they did not, they just denied the treatment. Wherever they went, they weren't allowed to get treated, and it's just penicillin. All right, high-dose penicillin treatment. Candidiasis. So this one I'll usually compare and contrast to leukoplakia. White areas of the mouth easily rubbed off. It can have a red inflamed. It can be like a burning once you wipe it off, burning feeling. It's an opportunistic fungal infection. Burning dysgeusia is just a fancy way of saying it tastes. Changes how things taste, dysgeusia. Sensitivity, generalized discomfort. So yeah, you'll see the trophic red patches or white curd-like. Chronic and denture-related patients, people who don't clean their dentures or leave their dentures in, can get candida that lives in the denture. So even if they're cleaning their mouth when they put the denture back in, it reinfects them. Here's what it looks like with the denture. You see how red and inflamed that is? So people who don't take their dentures out at night and clean the dentures, people who sleep in their dentures can get this. Really bad. And I hate to say this, but in my practice, it was always the little old ladies that didn't want their husbands to see them without teeth. So it was aesthetically driven. Like, I can't take my teeth out and have someone see me without my teeth, so they'll leave them in all the time. And then how do you treat it? It's really hard to get the candidiasis out of the denture. So you should be giving them a new denture. But a lot of times that's expensive. Like a new denture costs quite a bit of money. So they want you to try and treat the denture, which the acrylic, it's got too many holes, it's porous. It's really hard to treat. Diabetes, of course, is going to make everything worse. Yep, testing. You can look at this. I typically don't ask a whole lot about testing, but I know the other HEMT doctors do. Consider for HIV because it's opportunistic. Here's the treatment is antifungals. The troches, it's like they can suck on it. It tastes disgusting, but you can put these on the base of the dentures as well and have them wear it with the denture. Honestly, they just need a new denture. Mouth rinse also can help. None of this tastes good. Chlorhexidine is going chemical warfare once again, trying to rinse things out. Yeah, see how, again, you can apply powder to dentures, but my experience is it doesn't work. Angular cheilitis, dry cracks in the corners of the mouth. This is kind of fun when you see older patients with it because they are unaware that it's a candida infection. They're just used to having a sore in the corner of their mouth that doesn't heal. They have no idea that, hey, we can treat this and make it better. I see a question in the back.
Yes, sir. So for me, mom, what you wear for dentures is more blood. If you do go the route where you're actually putting a nice kind of powder on the dentures, you're also treating your system.
Correct. Correct. It's just hard to separate the two because, like, if she's constantly putting this denture in that has brush, she's just re-infecting herself, even if we're systemically treating her. So it's hard with older patients on fixed incomes to be like, we need to treat you and get you a new denture. And it breaks my heart because they're like, in the military, it's amazing. I can say this is the ideal treatment plan. I don't have to bring up cost with you guys. But in the civilian world, it's like, this is the ideal treatment plan. We need to do a denture. How much does it cost? What does my insurance cover? I don't know if I can afford this. Can you treat my denture? Can we save my denture? And I've tried it. I've tried it in the outside, and I've had not great results. I saw another question. Yeah, so if you, okay, I'm going to even go one step further. If you have a bad head cold, why aren't you throwing out your toothbrush and getting a new toothbrush? You do that. Good. So you're thinking ahead. Retainers and aligners. If you have thrush or infectious disease of the mouth, throw them out and get new ones. 100%. Yeah, how often should you be changing your toothbrush? And I know someone in here is gonna say, when you go to the dentist and they give you, every season, so every 3 months, you're right on. So I think fall, spring, you know, whenever, in San Antonio, it's hard because summer lasts for like 6 months for me. So like I start getting like, do I change it or not? But yeah, you should be changing your toothbrush head on your electric toothbrush or your manual toothbrush. You should change it out every 3 months. And if I have a bad cold, if I like have to take medications or something, I toss my toothbrush out and get a new one to help myself. But good question about the retainers. So angular cheilitis, and I have seen this on older patients, and it's that fold, the fold of the corners. That's where they get the Candida infection, right here in the fold. You see why this guy's corners of his mouth have that fold in it? When he opens his mouth, you see the upper teeth. This is, you know, I'm going to generalize again, take it all with a grain of salt. Guys who have dentures wear them not enough. So this guy has a maxillary denture that he never wears. So when he closes his mouth, he's hitting gum tissue on the top. We call that his vertical dimension is decreased, right? So you can imagine this part of his chin is up higher than it normally would be because he's got no teeth. And so now these fold in his lips can harbor fungal infections, bacteria, fungus, whatever. So if you see that, usually I'll try and tell him, hey, you should wear your denture more often, and let's get you an antifungal to help treat that. Do a little cream in there each day. And then they come back in, and they're like, oh my God, I didn't realize that was an infection. I feel so much better. It's really easy. Black hairy tongue, what is it staining? If I were to ask you, of all the things on the tongue, filiform. Filiform. So this is kind of cool. It's associated with tobacco use, coffee or tea. You'll get overgrowth of bacteria. You got to have really poor hygiene as well. But it looks like a shag carpet, guys. It's pretty cool when you see one. I get excited as a dentist. I feel bad because like sometimes I get excited and I ask the patient, can I take a picture? And again, I realize this probably isn't the bedside manner I should have for someone who's coming in with a black hairy tongue. But I'm like, this is pretty cool. I don't see it very often. I do get people who come in and look like this more frequently in the military after, if they're fighting GERD with Pepto-Bismol. Bismuth will stain it black. So they'll just take Pepto-Bismol at night because they have like an upset stomach. They'll wake up the next day and have a black tongue. And they're like, Doc, I don't know what happened. I got a black tongue today. And I'm like, did you take Pepto-Bismol last night? And they're like, actually, I did. I'm like, okay, it's just bismuth staining. It'll go away. Deep breathe in, breathe out. You're going to be all right. All right, so we get that black hairy tongue, very cool picture, overgrowth of bacteria with oral hygiene. You can get, you know, just kind of an overabundance of bacteria and yeast that are normally there. Superoxide mouth rinse. Someone was asking me about hydrogen peroxide. This is a time when I would say, go ahead and rinse with hydrogen peroxide for 2 weeks. You're not going to use straight hydrogen peroxide, you dilute it with a little water, but this would help clear it up pretty quick. All right, lumps and bumps, on to mostly benign lumps and bumps. Mucocele is I talked to you about this a little bit before when we were talking about minor salivary ducts. When you rupture a duct and now that gland has nowhere to excrete, it just kind of accumulates saliva in the gland and creates almost like a little balloon. They're pretty cool. They always look like this, kind of blue, clear, planeless. You can kind of push them around, they're movable, and you just have to extract them, like local extraction. Incise them out. Most people don't come in and have us do it, they just keep biting on it until it goes away. And they do a at-home dentistry by biting their gland until it's done. But mucoceles are cool. Randulas are under the tongue. Same thing, but instead of a minor salivary duct, it's a major salivary duct and accumulated saliva. So sometimes it's a duct stone that's in there. Most of the time, if I see this, I'm not touching it. There's a lot of blood vessels. I remember showing you that slide in the anatomy. There's a lot of vessels and stuff under the tongue. So I'll send this to the oral surgeons and have him look at it. See if they can find where that duct stone is and remove it. Fibroma, this one, yes, it's fun to take out. It's just a simple biopsy removal. And firm, solitary, circumscribed. It's usually on the tongue or on the cheek, sometimes on the lip. History of trauma. Sometimes you can even see where it's hitting against the tooth or against like a broken tooth that causes a fibroma. So the treatment is surgical excision. This is with dentures again, Epulus fissuratum. So this person has an ill-fitting denture and they don't get a new one, so they just keep sliding it, trying to find it, make it fit in the mouth, and it just, the way that they're doing it creates nodular tissue. It's weird, like seeing them try and fit their denture, and I feel bad for them because, again, they have a poor fitting denture that maybe they just couldn't afford to replace. And so it's chronically irritating and loose in there. But you have to remove the excess tissue, and then I wouldn't reline, I would probably make a new denture because there's no way this thing's fitting the right way. Inflammatory papillary hyperplasia, again, kind of looks like a cobblestone. So you'll see that palatal vault, poor hygiene, potential of a candidiasis infection, ill-fitting dentures, poor hygiene, candidiasis, and it turns really, really red and inflamed. So you have to remove the denture. I emphasize remake. I've tried relines, doesn't work as well. Treat the candidiasis, usually it's present, and then you can surgically remove anything that doesn't resolve after 2 weeks. So if you do the 2 weeks and there's still some areas of tissue that look red or irritated or not healed, we used to call this pregnancy tumor, now it's called pyogenic granuloma, but it's very reactive. It's usually due to hormonal changes, so you'll see it not just in pregnancy, you'll see it in teenagers. It's almost always right around the canine on the top. It's pretty rare to see it on the bottom, but it'll be red, elevated, bleed easily. Once they're done and they're delivering the baby, you can remove it. I wouldn't work on it while they're pregnant unless there was a reason. Lots of times there's plaque or calculus below. So with dentistry and seeing pregnant women, what I would recommend is first trimester, second trimester, third trimester. Which one do you think is the best to go get dental care? First? Third? So the third, my concern with the third trimester is how big they are, and the vena cava, when I leave them back, like it'll cut off blood flow, especially in the chair because I can leave them straight back. So in the third trimester, if I see them, I usually leave them sitting up and have to kind of hunch over and do really bad ergonomics on myself. So I'll see them in an emergency in the third trimester. For routine care, second trimester is usually the best. So like good cleaning, something else. You know, the first trimester, I'm worried about organs developing and other stuff I don't want to really interrupt. What about x-rays? Are x-rays looking I'm pregnant? I avoid it. I mean, it's one of those things like, unless I absolutely have to, I avoid it. But if I did, and I put the shield on, it should be fine. However, if there's anything wrong with that child, they might think back, I did see the dentist. And so, it's kind of like Tylenol now, I guess. It's in everyone's mind. It's like, Mom, did you take Tylenol? Because look at what came out. And I feel like correlation is not causation, so we have to be very careful. But I try not to give them anything that correlates that they can trace back to. But getting cleanings during pregnancy, absolutely. Routine care, aside from a cleaning, I would probably say, hey, let's wait and do these ones until after you're done. Now, if it's an emergency and you're in pain or there's an infection, come get seen. We're going to take care of this right away. And so with this, it's not necessarily an emergency, but if they're in enough pain, I would remove it. I wouldn't take an X-ray, and I would prefer the second trimester. Squamous papilloma, local excision. Yeah, not a whole lot here. You have to send it to the pathologist so they can tell you which virus, which kind of papilloma it is. So in my opinion, a lot of the papillomas all look the same. This one's described as white, pedunculated narrow stem. Okay, now we're going on to the fun stuff, the STIs or malignancies. These are the bad ones. So fun facts about oral cancer. Let's go. For oral cavities, or for the oral cavity, the most common site is the lateral border of the tongue, period, followed by the floor of mouth and the retromolar pads. So when you go in for your dental exam, hopefully what the dentist is doing is saying, will you please stick out your tongue? They'll probably grab it with some cotton gauze and look at the lateral borders of your tongue. reason we do that on pretty much every exam is that is where the majority of oral cancers are. It's on the bottom of the tongue. Floor of the mouth. So I'll also ask the patient, can you please touch the roof of your mouth with your tongue? And I'll try and look at the floor of the mouth, trying to rule out oral cancer. When I take my mirror and I'm looking in the mouth, I'm trying to look behind the last tooth on the bottom. That is the retromolar pads. Where is it at? Lateral border of the tongue, floor of the mouth, retromolar pads. So the pads right behind the last tooth in the mouth on the mandible. So that's what we're looking for, any kind of cancers on the oral cavity. Squamous cell carcinoma, 90% of oral cancer. So if I, being not very tricky or very smart, put oral cancer question on your exam, I want you to think, could this be squamous cell carcinoma? Because that's 90% of what it should be. You know, so it's the most common, it's what I want you guys to know and to look for. Salivary gland tumors, most common is the parotid, that's where 80% of the tumors are, 80% are benign. And then we got submandibular and then minor salivary gland tumors. So I always say it looks like someone's trying to smuggle a baseball in their cheek. Like it's pretty obvious, you're looking for a symmetry, and this is obviously asymmetrical. Mass in the salivary gland can have some facial nerve involvement, so they can't smile or raise the corners of their mouth as well as normal. So usually, yeah, imaging MRI is preferred. Resection of the gland, who's going to do this? It's not going to be the general dentist, right? It's going to be the oral surgeon, and they usually have a board that will meet, the cancer board, and they get everyone on board. So they'll have the ENT in there with the oral surgeon, with the oncologist, and some other specialists, and they'll all decide how they're going to attack it. Okay. Radiation for larger or invasive tumors, yes. Condyloma acuminatum. So this picture always makes me a little angry. I don't like this picture because that is a child. You see the child's teeth, they still have mamelons on their incisors down here, and they've got condyloma acuminata in the mouth. So presence of condyloma acuminatum in a child is suggestive of sexual abuse and has to be reported. So this is multiple papillary. It can occur in the lips, tongue, soft palate, and most common is anogenital lesions, which is not my cup of tea. That's not where I'm looking. But when I see it in the mouth, then I have to ask about sexual history and partners, and I should not be seeing it in the mouth of a child. STI caused by infection with human papillomavirus, and has to be excised and biopsy. Verruca vulgaris is another one, common warts. To me, it looks a lot like the papilloma that we talked about in the last one. Like this, I guess, has more of like a broccoli or cauliflower head. They all kind of, these white ones all kind of get me. Like I would just, you see it, something new, it's not resolving, we're gonna go ahead and biopsy and send it out. Same thing, pedunculated, white, solitary lesion, and then they'll give you the diagnosis. So excision is the treatment. All right, cool. So now we made it to squamous cell carcinoma. You guys, does that look normal? I kept showing you what all the normal stuff looks like. This is what abnormal looks like. Non-healing, firm, indurated, possible of referred pain or local pain or even paresthesia. High risk factors with tobacco use and alcohol use, solar radiation. I think I just described Cab Scouts. Like tobacco, alcohol out in the sun. Yeah, we have a high risk for this, like with certain, I feel like MOSs or AOCs in the military. Hello? Yeah, so this is a bad one, and I wouldn't even go with a routine brush biopsy. You want to do something more aggressive if you can immediately to get this out there. Appropriate combination of surgery, radiation therapy, and chemotherapy. This is the one I think I told you we want to rule out when we see an amalgam tattoo because it can present with the same coloration. Remember the A, B, C, D, E, the asymmetry, irregular borders, variable color, increased diameter, whether it's elevated. Remember, it's going to be changing, so it's going to look different in the patient. frequently diagnosed in later stages because patients and providers fail to recognize it early. I mean, how hard is it to see on the roof of the mouth? Like, who's looking in there besides the dentist? This might be a little bit easier to see. Other places with melanoma that you can see it is on the palmar surfaces of the hands and the feet. So it can be hard to see. I've seen it before where they spread the toes and they see the discoloration in between the toes on people. So in the mouth though, it can hide as well. And this can be one of the first spots to spot it. Malignant melanoma, same thing talking about. Rapidly enlarging, yes. Extremely aggressive form of cancer. Patients with oral lesions generally have a poor prognosis with a bad 5-year survival rate. All right, so this is my keys, and this goes, I feel like, more than just for dentistry or oral. But anything that is well circumscribed, has symmetrical borders, occurs bilaterally, is more likely benign. So anytime I see something weird on one side of the mouth, I look on the other side to see if it's there too. Because if it occurs on both sides, it's more likely benign. If it's only unilateral, it's only on one side, I'm concerned. If it doesn't have symmetrical borders, so if it's asymmetrical and it just looks odd, I'm concerned. Hard or indurated, I'm very concerned. There's my 2-week rule again. An oral lesion has unknown etiology. You don't know what's causing it. The patient doesn't know what's causing it. 2 weeks, we need a biopsy. Let's go through a couple of example questions. White lacy areas. I could say Wickham striae, I think, would go with this as well. Y'all know which one it is? C. All right, 75-year-old female, ulcerated lesion on the anterior, so on the lateral aspect of her tongue. Non-healing. Which cancer am I trying to describe with words? B. Good. And that's, if I were to, I feel like this one, if I include pictures, y'all should be able to see it pretty easily. Questions, discussions? I told you that the first 2 days were the long ones. These ones are easier. Tomorrow will be the shortest of all. And I'll bring in like some old questions I have and try and review them with you and show you what I'm thinking. Any questions for me today? Concerns? Complaints? Yes.
At what age would you recommend getting dental X-rays on children?
I think the first time that we usually, since they're going to lose them all, now you're like, they're practicing, what do they matter? I think the first age that we try and get X-rays on is usually associated with like them going into kindergarten, if I'm not mistaken. I'm honestly a little bit sad. I can't say right off the hand what the recommendation is, but I've been out of seeing children for so long now. But yeah, I think 4 or 5 is when we usually start taking X-rays on children. Any other questions? They will do X-rays earlier if there's carious lesions or a cause or reason to take them. But in general, I think that we don't do it until all of them are erupted, probably around 24 months. But good luck trying to have a 24-month take an X-ray. Another question? No, just a stretch? All right, well, thank you. You are free from